The mental health care pipeline is broken. Millions are staring into an access gap that human clinicians alone cannot close. 122 million Americans live in a designated mental health professional shortage area. By 2037, the country will be short 88,000 counselors. In 2024, 48,824 Americans died by suicide. A senior Silicon Valley voice argued to me last week that these numbers make unsupervised AI a moral imperative. He believes the access gap is so lethal that the only solution is to remove the human from the loop. The first premise of this argument is that the technology is ready. He claimed that AI is already a better therapist than 75% of humans. His second premise is that requiring a licensed therapist to supervise the AI, a model called therapist in the loop, is a bottleneck that kills the ability to scale. This creates a specific math. He is betting that the body count from AI failures will be smaller than the body count of leaving people without care. We are going to walk that argument out as far as it goes, testing each premise against published evidence, longitudinal outcomes, and existing medical regulations. What the evidence shows is that the investors' premises don't just fail to solve the access gap. They describe an architecture that scales clinical risk. The 75% claim is the most powerful talking point in the anti-supervision argument. It is also the most fragile. The primary source for this number is a study titled When Eliza Meets Therapists, published in February 2025 in PLOS Mental Health. This study asked 830 laypeople to rate text responses to fictional therapy vignettes. ChatGPT wrote one set. 13 human therapists wrote the other. The study found that laypeople preferred ChatGPT's prose style, but it did not measure clinical outcomes. Contrast that with a separate study from the American Psychiatric Association using the cognitive therapy rating scale. Here, 75 mental health professionals rated AI versus human therapists using actual clinical transcripts. When the raters were trained clinicians, the findings flipped. 29% rated the humans as highly effective, while less than 10% gave the AI that same rating. A second study from Centio University used that same 75% figure, but the authors admitted the pool only included people who had already chosen to use AI chatbots. Equating a layperson's preference for prose with actual clinical efficacy is a misalignment of methodology. It's a calculation that allows policy to be built on an incorrect interpretation of the data. The strongest evidence for clinical AI is the Therabot trial at Dartmouth. It showed a 51% reduction in depression and 31% in anxiety, but the lead author, Michael Hines, was clear: the system was never autonomous. The team was equipped to intervene immediately if a patient expressed an acute safety concern or if the software deviated from best practices. The investor's argument assumes that autonomous, consumer-facing models will naturally get safer as they get better at conversation. The longitudinal evidence shows the opposite. A 2026 study from Aalto University tracked nearly 2,000 replica users over 2 years. They monitored symptoms of anxiety, depression, and social isolation. The outcomes worsened over time. The longer people used the autonomous bot, the more their symptoms of depression and suicidal ideation increased. This pattern was documented again in a Stanford study, focusing on what they called delusional spirals. Chatbots are becoming more fluent, but that fluency is exactly what makes them dangerous in a clinical context. The AI is now capable enough to affirm a patient's paranoid delusions or ignore a crisis while continuing a convincing conversation. In this architecture, capability and harm are linked. As a model becomes more conversationally fluent, its capacity for complex clinical harm increases. The theory of an acceptable body count is failing. Real names of victims are entering the public record today. Wrongful death suits have been filed against OpenAI and Character.ai. Families are testifying before the Senate, describing bots that acted as suicide coaches, researching methods with children, and talking them through crises without escalation. This has triggered a federal response. 45 state attorneys general have issued warnings, and the FTC has opened formal inquiries into 7 major AI companies. Currently, the system is reactive because there is no federal FDA database tracking adverse events in AI mental health. The American Medical Association is now asking Congress to fund exactly that kind of registry. Because the industry moved without supervision, Wikipedia has become the de facto adverse event registry for the field. The wellness app Safe Harbor is collapsing under the weight of these records. We return to the final premise, the assertion that therapist in the loop breaks the math of scaling care. The argument relies on a specific assumption. It treats therapist in the loop as a traditional one-to-one delivery model, where the human provides every interaction. But that is not how any other medical specialty scales. In radiology or psychiatry, we use the physician-led care team. One licensed doctor supervises a staff of practitioners. Federal regulations already support this. VHA Directive 1027 authorizes telesupervision, allowing one clinician to carry responsibility for multiple practitioners across massive geographic areas. The Counseling Compact stretches one clinician's license across 38 states. If that clinician supervises AI agents executing CBT protocols, the math changes. The clinician handles the license in crisis escalations, while AI handles the daily caseload. The ratio scales to 1 to 1,000. The investor's math assumes the license is the bottleneck, when in reality, the license is the framework that allows the system to scale safely. The access gap is real, and the investor is right to be angry about it. 122 million people are waiting for care that isn't coming, but the autonomous AI bet is leaving a growing list of casualties in its wake. Speed to market is not the same thing as a solution. The architecture that actually closes the gap is the one that scales accountability. The AI accesses the staff. The human holds the license. Supervised AI is not a bottleneck. It is the only legal, clinical framework capable of reaching the scale of the crisis without sacrificing the patients it's meant to save.